Hello and welcome back to the Addiction Unfiltered show. I am Isabella, a recovering alcoholic.
And I'm Laura, a recovering alcoholic as well. And with us today, we've got Miss Janet Kantalama, a leading expert in the addictions field. Welcome. Thank you so much for joining us.
Thank you, Laura and Isabella, for the invitation. But if you give me big things, leading expert.
Yes, you are.
Leading. Janet is one of the directors, or, she will introduce herself more, of the treatment center that I went to, that I have talked a lot about, safe places. So you can see, for me, she is the leading. I look at her and she's the reason I am here like this today, So yeah, that's how leading she is in my life. So yes, and I'd love for you to all hear all this information. So yes, the topic today is addiction in females, in women in Uganda. We would love to shine the spotlight on women. We find that because of all the stigma and everything, it is just not talked about as much. And so, yes.
Okay. First of all, I thank God that we were a vessel through which you got your recovery, and many others have gotten their recovery. There are many others out there. And I want to commend you for coming up with this pay forward. Okay? It's very, very, very important that actually people who are in recovery speak about the recovery so that they can encourage other people to come through and get their recovery. It's like a new chapter, opening up a new chapter. And yes, safe places was your path, but your recovery is you put in work.
Yeah.
You have to put in work, and then also, of course, God above all. So I'm honored to be here, really, and also Isabella. Of course, we also have, we have our history, just like Laura.
Yeah.
Just like Laura. But so it's also important that we speak about the women. I am personally interested in women and anything to do with women affairs, and especially women and their mental health, including addiction.
Yes.
So it's good to open up this space so that we can speak about it. We often find that that people think that addiction, when they talk about addiction, it's only a male thing,
Yeah.
Like these men got spoiled in school, or they were very stubborn, or they were,
Yeah.
There's this whole narrative about it being predominantly for male,
Yeah.
but we know it is not true.
Yeah.
Okay, we know for a fact that it is not true.
Yeah.
That actually women and addiction, why it is not as emphasized, it's because of the stigma. You see, women, alongside being women, they are mothers, they are wives, they are sisters. So I want to paint a picture of this gentleman whose wife is in addiction. How much stigma do you think he will carry?
As in, he would rather hide her, try other things, try churches, before actually thinking of rehab or treatment.
So imagine this woman is a mother to relatively adult children. What do you think the perception will be if she actually is in addiction? From the children's point of view, from the husband, from the family of the husband,
The school
from
of the children.
school of the children.
She's just a failure. She's not serious. The whole poor children, poor wife. No grace for the woman or the mother. It's all about she's failing. Like what's wrong with her?
Yeah.
Exactly.
Yeah.
And so imagine this woman who is a daughter in a family where we still have patriarchy. We're not forgetting that we carry it along.
Yeah.
And of course she was educated and she was given all these privileges, and then she drinks. Or even beyond just drinking, because we are talking about addiction. There are also other addictions that we are not talking about yet, but they're there.
Yeah.
So what do you think will be the small family attitude towards this person, the big family, because we also have to know that, So what do you think will be the attitude towards those people?
Yeah.
And so if you don't see the women coming out to seek help, or if you see the women being misdiagnosed for, she has she has either, another disease that is not that, then we clearly understand that it is the too much stigma, which comes with their role and positioning as women, which comes with the society, the social norms that are associated with being a woman. So it does not mean that actually women are not in addiction or they don't get into addiction. They do. We can even say they get into, equally. Because there's no biological, major difference. They are there. Yes, the numbers come through. You have to know that when you look at the statistics, you see that the people who are seeking help for addictions, who are recorded as people who have gone through substance use disorders, the majority are male.
Yes.
But we know that there are factors that are preventing the females from getting counted. So when you're looking at it fairly, you could imagine that there could also be the same amount. Where we are aware, where we know free of this stigma, and we had seeking support and help, probably you could see the numbers are the same. So addiction is real, and very much so.
But
in women.
I was just thinking, for us it's obvious, but maybe before we even go far, according to you, according to this leading expert,
Laura,
what is addiction? Okay,
and we are going to use our understanding. Okay,
that's your understanding.
The one I want someone to adopt, because we get very many people asking that I drink every day. Am I an addict? You have those questions coming through.
All the time. I always pass by my kafunda before getting home. Am I an addict?
Then you see, when I'm on leave, there's no reason I shouldn't binge. But me, if I don't take my 2 sticks, I will take my 2 sticks of weed, but I'll still work. So we have all those perceptions about addiction. But we have to look at it in the sense that that substance or that behavior, I want to put an emphasis, because there are also behaviors. Behaviors are often not talked about because they think that you want to have something real. You're drinking alcohol, you're smoking weed, you're sniffing cocaine, you're doing all these other things, drugs, but then there are also behaviors. So is that behavior or is that substance controlling your life? That is it. Has it taken over your life? You might not know. Few have awareness that they know that now this thing has taken over my life. But the people around you will make it a major point about you. That are they always talking about that substance or that behavior? Okay?
When you don't show up for a function, is it like, oh, she must be drunk?
She must be drunk.
No, when they loosely throw around those comments, and it's just generally known.
Is it defining you? Is it defining you? Of like, okay, no, she had a quarrel, maybe, and a legit one. You could find that it was a legitimate issue. And say, that's her drunkenness.
That's her,
Or the person you go out with friends and the person disappears. That one is off.
We shall see him again in 3 days.
So, is it defining you? Are there consequences to that behavior, personal and social consequences resulting from that behavior or that substance? But regardless, are you still seeing no problem with that substance or behavior when there are consequences? Have you promised or attempted, you as an individual, to actually stop when in your deep recess or when you're alone and there are consequences, and the next day and you want to say, you vow, I am never ever touching this again. And before you know it,
that evening,
not even that evening, even when you have told everyone around you, you promise, you swear upon the Bible and the Quran, and you say upon all the good things you like. But that very evening, you're back to that substance. Even when you give yourself very good reasons, you see, I drank because I was at a party. If I had been alone, if I hadn't been invited to the party, you see, you rationalize the drinking. But the thing is, you promised yourself, you attempted to stop, but you have failed to stop. Is that thing, that substance or behavior, causing social disharmony or poor interrelations within, your family, yourself? This is when everyone, because of that thing, you have conflict with everyone around you. Because of that thing, you cannot be productive. Your job is suffering. If it's school, your school is suffering. So there is social disharmony that is coming from that substance or that behavior.
Yeah.
So when I emphasize behavior, people say, but like what kind of behaviors? So I'll tell you the different types of addiction. There's addiction to the substances, but there's also behavior addictions. And we can look at the most commonly occurring substances.
Yes.
And even in women, because you see people say, but do women smoke weed? Oh,
Yeah.
oh yes, please.
That was going to be one of our questions. Like, tell us the types of.
The
because
types of,
Izzy
yes.
and I mostly talk about alcohol, right?
yeah.
Because we're alcoholics.
Yeah.
But there's so much more. That's just one out of many, you
Yeah.
know. So that's one of the questions we're going to ask you as
Yeah.
well. You know, to tell us, especially at the center, what you witnessed, the you know what people what they get admitted for, you know, usually what are the common ones?
Okay. So at the center, and through my experience, not just at the center, as a psychologist or a behavior specialist, the commonly occurring substance disorders or addictions are alcohol, number one. Weed, which some call THC, which some call cannabis, which some marijuana, I think is a second in there. Then we have, of course, cigarettes. You know, people cigarettes think that there's a ban on cigarettes. You know that there is a law outlawing smoking cigarettes in public and whatever.
Yes.
But you know, we also have shisha.
Yeah.
So there is a tobacco in there. Okay. And tobacco usually comes as a second, like you drink but smoke.
Yeah.
Yes.
Yeah.
You do weed, but sometimes you do, you know,
The shisha.
you do the shisha.
Yeah.
Okay. Then we have meth. Okay, which some people call ice as well.
Ice, cocaine, or
No.
just ice.
Yes.
Yeah.
Okay. Then we have crack cocaine.
That's the word I was looking for.
Crack cocaine. Then we have actually pure cocaine. Then we also have pain medication, like proper prescription drugs.
Yeah.
I was looking for the word.
Tramadol.
Yeah. That's
We have the codeine.
yeah.
Yes. Codeine shocked me. That's cough medicine.
Yeah, we have the
And also
codeine.
cough medicine.
We have morphine, pethidine.
Peth,
yes.
Yes, very much so,
Pethidine,
especially
yes.
in people who have easy access to it.
Yeah.
So substances. I
There's
think,
also the sleeping pills, I think.
Yes.
They've become quite prominent.
yes. We also have the benzos. But
Yeah.
so you see, the thing is sometimes there is a thin line. We want to educate, but also we don't want to give you tools and ammunitions.
Like, please don't take these as notes. They're
No,
not.
I came out of the center having learned very many types of drugs.
Exactly.
Yeah.
So, but what we're saying is, these are dangerous things. They can ruin your lives.
Yeah.
Okay?
Yeah.
They can ruin your lives. We're just, for that parent who doesn't know that there are several. Those are only a few of them that we have mentioned.
Yeah.
Okay? Then the other most occurring behavior addictions. One, gambling.
Yeah.
Then pornography.
Yeah.
The masturbation.
Yeah.
Like take over people's lives, that it comes with something else. You know, your life is not the same with them. Behavior, of course, there is this one is a bit tricky. There's lying.
Really?
Yeah. Pathological
Can
lying.
get
You
a-
can.
Yes.
As an addiction.
Okay.
Interesting.
It is a behavior.
Yes.
What is a behavior? What is a scientific term? But there is that to telling untruths and things
Yes.
like that. And then there is
Levels where it's unnecessary, but it's become a habit.
and it doesn't have, because you see addictions into other substances also come with issues with telling the truth as a behavior, a behavioral issue.
Yeah.
But then it can also occur on its own. Okay. Of course, there is kleptomania. I mean, there's also just stealing. People say, but stealing is bad manners. So I wanted to talk about addiction as not being bad manners.
Yeah.
Yes, because sometimes we say, but she told stealing, that wasn't bad manners.
Yes.
They didn't beat the kid,
When they're growing up.
when they're growing up, it's nurturing and things like that.
Yeah.
Spoiled.
So, but we have to know that behind addiction, there is a process. There is an impulse control issue there is a disease of addiction that we can talk about. I believe, Laura, that you went through all those sessions. I believe, Isabella, you guys are aware that sometimes, even when you say that I am promising myself I'm not going to drink, that biology calls you to what?
Like you actually mean it when you say it. You're like, I'm not going to drink today, and you mean it. Even the person you're telling, you really mean it. But then the biology, like as you said, by the evening, there's nothing else you're thinking about except where can I go and get that fix.
So I think those are the most commonly occurring. If there are any that I have forgotten, we could maybe if it comes back, then I can let our audience know about them. Yes.
Okay, so since we're talking about women, females in particular, I wanted to ask like how many are suffering from addiction, but I don't know if you'd have those statistics, or at least a percentage, let's say at the center. Is it at 30 to 70%? Is it?
Like as I said, Laura, that you see, we have very many barriers to access. Access to care for women. Like there are very many barriers. One being stigma, then the other being the social roles they take on. That someone will say, but she's a mother. That this person who is an addict still has to take care of her children. Okay. Then you see there will be that, how can she go away from her home for all this while? We get all those are by the reasons that people are calling in and saying this lady needs to come into care, but
how can she?
But how can she get the support?
I mean, that was I went through all that when I was making that decision to go. I'm a mother as well. Like, I had to work. I had so many responsibilities. A family where it was like, what will they say? Where's Laura? All those things. But and because of all that, something that I noticed was even when I was checking in. It was a funny story. I checked in with my brother. My brother is very absolutely does not look anything like what I mean?
On that side,
So they look at me. I'm carrying I'm holding a handbag. I look like that. Not like this today, but I look okay. And then so they were so convinced. This I heard from the other clients at the center. They were observing all this, watching the admin block as I was checking in. So they were so convinced that the sick person or the addict was in the back, or was in the car. That we were just coming here arranging all this, and we're going to go and get him. That's why he had blacked out. I mean, the person had blacked out in the back seat. Why am I saying this? Because they don't usually see women come in like that. Because what I noticed, right? By the time a woman checks in, she has tried everything else. Usually they're even in psychosis because the family has kept them away, or they've kept themselves like, this was what's after plan Z, like the very last. So they were not used to seeing someone check in like that. And that's what I noticed, like even at the center, most of the women would come in with psychosis. Psychosis meaning in like
well, you're expert in this.
When reality is here and basically.
So basically it's a stage it's a severe stage of either addiction or other mental health conditions. And you're correct. I mean, that observation is correct to a certain extent, that because of these factors that we've been talking about, that help seeking comes at the end. Yet if we had, if the person had come a little bit earlier, even the process of healing would be easier. The chances would be higher for the person to attain recovery quicker. And so we end up having them at the tail end, and then the work has to be a little bit more, the stabilization.
And their recovery process is also harder.
It's also harder.
And then you also have to know that sometimes addiction doesn't only occur alone, because there are some conditions, and we see this a lot in women, that there is a co-occurring condition. So maybe for our audiences, they also need to know that addiction is also part of the group of mental illnesses. Those people want to distance it, but the person is not mentally sick.
It's
because there is a stigma about the mental sickness. So what we are saying is, does it affect your brain? Does it affect how you think? Yes, addiction affects how you think. Does it affect how you feel, your emotional wellness? It does, doesn't it?
Yeah.
Does it affect your behavior? your functioning, your productivity, doesn't it? It does.
It does.
But it's also scientifically categorized as a mental illness. You know, that is among the substance use disorders, okay, or behavior disorders. So it is categorized like that. But what I wanted to point out is that most women come in with a co-occurring issue, and that can be like depression, or it can be bipolar, and then they are also drinking. It doesn't mean that they will do that all the time, but it can. It's common.
Yeah.
You'll find that
One triggers the
yes,
other.
it's common that they have. There is an underlying other mental illness, and then there is addiction, or there is a chronic illness, and there is also addiction. Yes. So I think to what you asked earlier of the numbers, I believe that, Laura, if it was like up to the awareness standards that we need, up to the society, like their ability to fight the stigma, the numbers would be almost coming to a sense. But as we stand right now, you could find that it's a ratio of 2 to 1, male to female, those seeking help.
So actually, I wanted, because Laura talked about briefly her check-in, and not to talk about the check-in of a patient, but for people who we're talking to, our audience, who might be saying, okay, so far, I think I have a person, or I am a person who needs to go and go to this place. But they're scared. I remember my check-in, I remember being so afraid once I got there. I don't even know why. It was not a scary place, but I was scared. So what does it look like? Can you just maybe take us briefly through what a check-in process to a rehabilitation center is? But also, I think we haven't actually talked about what that means. We keep talking about safe places, we keep talking about the center, we keep talking about recovery, we keep talking about the treatment, but I don't think we've told our audience what we're talking about. What are in-treatment rehabilitation centers, and what is that process like?
So it's residential care for either a mental disorder that is not only addiction or addiction. So when we say rehabilitate, it's restore someone to their previous state of well-being. But then we also have people who think that rehabilitation is only for drugs. You know, there is physical rehabilitation. You can have your body physically rehabilitate. You know, there's also social rehabilitation. There is behavior rehabilitation. So you just restore a person to their previous state of wellness before the disease. So when we say when a person needs to come in, for example, to safe places for a check-in or for an inpatient program for addiction, then they come to like any other, like a hospital. You know, you come and you've been diagnosed, or there's been an assessment, and there is need for you to get intensive support for that disease. So we are given that we have two options. We have the voluntary, where a person can say, you know what, I need to check in. I also need to caution people, because I keep saying that, you know, but they don't want to accept, they don't know that they have a problem. And I keep telling the parents that how do you expect a person whose thought process has been affected severely to know that they need help?
It's literally been hijacked by this addiction.
So the addiction or the disease, state of disease, has hijacked the person's executive functioning, which is the executive function is the logic, the sequencing, the memory, the thinking, the planning, the things that make you be responsive and logical and understanding. So we have two prongs. There is the voluntary and the involuntary. And people will say, but there's no involuntary care for malaria. Yes, there is no involuntary care for malaria, but malaria will affect the physiology.
Yes,
it will not affect your functioning. And so that is why there was a provision for that. That actually your loved ones can see that this person is descending into severe states of unwellness, and together with an opinion of a mental health worker, senior mental health worker, and of course the law enforcement, the police, are mandated to take care of this person and get them into care.
Yeah.
So that's why you see that there will be those who walk in, and then there will be those who will be brought in.
Yeah.
Yes.
And so people say, but if you bring in a person when they are not ready, and then what are the chances? Actually, the chances are 50.
Yeah.
Because recovery is on the outside. It is when you come out, when you're in treatment, you're given all these tools.
Yeah.
So a person can come in involuntarily. What we know is that they are getting them to see their problem will take a little longer, but some will get it.
Yeah.
Even those who come voluntarily, that they can reach halfway the process and realize realize that this is like harder work than I anticipated, and give up.
Yeah.
So it is not guaranteed that because a person came in willingly that they will attain their recovery.
Yeah.
Or that the person came in involuntarily that they will not attain their recovery. No, the chances are 50-50.
Yeah. And I keep saying that there's people who always say, but no, I know someone who was forced into rehab. There's always those arguments.
Yeah.
And you know how you said there's a 50-50 chance? Think about these families. Wouldn't you rather take that 50-50
chance, exactly.
that chance than none at all?
Than none at all.
And by the time people are taken into rehab by force, then you can imagine what's happening at home.
Yeah.
There's either so much destruction of property, destruction of relationships, everything. And the families just no longer feel safe or just usually worried about that. You're going to die in a car accident, you're going to kill someone, whatever it is, right? Consequences, things that just can never be solved, that would affect the person's life forever.
Yeah.
Do you know?
Is true.
I was always that person, defending Brett TR. So many people get it twisted, get upset about it.
But you also know that there are even previous interventions before that last smile. They've talked, they have called all the family members and sat this person down. They have written agreements.
Yeah.
They have threatened, they have put ultimatums.
Yeah.
These persons have even had consequences which have led to imprisonment.
Sometimes, that's what they've even tried.
The family has prayed, the family has fasted, the family has taken to pastors, the family has also gone to witch doctors. The family has, basically, there has been an attempt to help this person. Yes, several. So usually when they do the last mile of, it's involuntary, you feel sorry for the family. They actually have no alternative.
Yeah.
Then I get people saying, but they could have told me they were bringing me here. And I ask, don't you think they have had those discussions with you?
Yeah.
Or would you have allowed?
Yeah.
Had you known?
Yeah.
Sure, let's go.
When would you like us to leave, right?
Had you known, would you
Actually,
have allowed?
where I was, there was even a question that was asked where the person would say that, and then the response was, do you remember arriving? Because had they told you were coming, would you have known? Because you didn't know when you came. So surely it didn't matter whether they told you or not. You don't even remember arriving. So at those stages, honestly, it's a last resort. I don't think any family, like you rightfully said, is trying to force anyone into rehab as a first option. Exactly. That is usually the last. They have tried everything else.
And also the other everything else, there's also outpatient therapy. There are those who have tried. I said, okay, no, I don't want inpatient, you come. And we also caution, and we tell you, what the challenge with inpatient for addiction is the access.
With outpatient.
Yes, the access to those very things that we are trying to get the person.
Even just between that appointment, your outpatient appointment, to home.
Yeah.
The number of buttons and everything to go by. You
all
have your phone,
of
you
them,
have
everything.
Yeah.
So when
it's harder.
Exactly.
Yeah.
So when a person comes for inpatient, the quickest win is abstinence.
Yes.
Yeah.
That is one thing. That is one quick win.
Yeah.
And you say at least
abstinence, detox.
Yes. At least let your body be for several days or weeks or months without this substance.
Yes.
Yeah.
Anyway, so back to the process of when the person is coming in. So there's that involuntary and voluntary check-in. They have to come with a person who is a next of kin because they have to sign them in. A person can sign themselves in, but also need another person. If, for example, those have been picked and brought by police, then the police person takes the witness role and signs this person in, because we want to know who this person is that they are bringing to the center. for the protection of the person as well as for the protection of the center. Then when the person comes in, then they do assessments. Assessments, the person might not be in that mind frame of now asking questions, but there's also physical assessment. You see, people think that assessments are only going to do the mental one immediately. You have to clock the person in. You have to know how have they come, how are they presenting, what is their appearance, how are they, like, basically. You're looking at this person, they're coming in. Then if a person is not in a state where they can give you any information, you definitely will do some like the physical examination. And then we also get history or information from the person that has brought the person. Why have they brought the person? You know, what are the concerns? What are we dealing with? That is when they will tell you this person has been convulsing. The person might not be in position to tell you, but that is something. Is there any medical history that we need to note, to take care of? So that is at the intake. So as I said, that some people come in when they are not in a state to do any exams, to do any assessment. Then you wait, you leave that for a later, like tomorrow. So we usually try not to leave that 72-hour window without getting a hold of the person's like state, proper state. So the person will then be taken in, and then the rooms, of course, the rooms are varying, and people say, is it like, are there bars and you're locked up? And, and
that's why this is called demystifying.
Yeah, we're demystifying, because again, I didn't know what rehab was, and I mean, even after
like prison.
Even after Googling, even after I still arrived thinking I'm going to prison. And they're going to be bars everywhere, and there's going to be gates that lock, and there are guards to lock them, and
you're in a cell without mattress and beds and things like that. So there is this really misconception, and it's actually a place of abode, a comfortable place. You will find a room. If you're in a state that you can stay in a single room, there is single occupancy. That is also assessed at the beginning. But for us, we have a seclusion room that every person that is arriving, even if they are going into a single room, you first put them in a room where they can be observed for the first, at least, like intensely observed for the first, like, 72 hours. Because some come in a state that is not okay. Before then, they are assigned their other, like, on the ward, they are given rooms that they should go into. And then, so the rooms vary from single occupancy, double occupancy, 4 people, 6 people, maximum. Like 6 people, it also depends. Because some people, some of their behaviors are self-isolating. So you can't put a self-isolating person in a single room. Or you can't put a person who has had suicidal ideation in a single room. Okay? Or you can't put a very advanced age person in a 6 people room.
So there's different options for
different people, but also tailored to the person's need and the person's need, like health need, and as well as other factors need. So the person is taken to the observation room, and the nursing team then takes over. If there is a medicine that has been prescribed by the psychiatrist, then it is administered. Then the person is made comfortable for that period of time. Oftentimes, of course, if it's addiction, then we'll have the withdrawals, the withdrawal syndrome coming in, and then that's when, if the person is, of course, in psychosis, as Laura talked about, then they are not in a state where, they will find you, Isabella, and tell you, Isabella, why are we here? Why are we not home? You and I, my daughter, why are we not home? If it is a person who is hallucinating or... So basically, the presenting symptoms are then handled. The person is treated for that. So that goes on until the person is stable enough. So there is 3 ways. There is biology, as I said. We need to first make sure the person is physically in a space or in a place to actually partake on the psychology. So while we are managing, that is, so the first, depending on the stage of arrival, that first period, maybe 2, 3 weeks, 4 weeks, is more intensely psychiatry, or the clinical team doing the work. The person is not sleeping, the person is not eating, the person is very weak, the person is
malnourished,
vomiting, the other. We've done tests, I forgot the bit of tests still in the 72 hours. We've done tests, maybe the person needs some other treatment besides just the addiction. There are all these health conditions that need to be handled. So it doesn't mean that when a person is within that first month, they're only doing the biology, the physical. There's also other, they still do the psychotherapy, but we know sometimes that some are not actually in a state to have one-on-one therapy or group therapy.
Yeah.
So we are doing that. It is available to them, but it's mostly a check-in to see how is this person doing. If you can have a conversation, can we have a coherent conversation with this person? So that is it. Then after, of course, there is a schedule. Even while the person is in that state, we try to start introducing them to a schedule of life. I know that that schedule is also troublesome. But like, why are you treating us like school children? Why do you want us to wake up early? We are adults.
We actually, so where I went, we actually, and this was on me, I can be cheeky. So we ended up calling it a cohort, and then we called the sessions classes.
Exactly.
At one point, it was the therapist was saying, if you start calling us teachers, we are sending you away. Because of that schedule, it's like, there's meals at this time, there's sleeping at this time, there's session at this time. Yeah, it is. It's like being back in school.
And something, rehabilitation.
Yeah.
We are getting you back to a state whereby it's not just school, like our everyday life.
Yeah.
Even without anyone pushing you.
You have to get up.
You have to work out. You have to take your children at school at 7:30. You have to go to work at 8. You have to have, so there is a planning element that is important in your life. So that is just you trying to get you back into the routine. That is life. So while even that, so we have a schedule. I think, I believe, Laura, you have spoken about the schedule. And so that schedule is to help you, as I said, go back to routine. But then we're also dealing with as I said, the addiction, but addiction comes with behaviors. So what we see is behaviors. So we try to first surface behavior and then see what is underlying those behaviors. So there will be a person, the chances are there will be medication to the person to help in the first month, detoxification. And then there will be psychotherapy, which is individual and group. Individual, those lessons, you call some of them. Some are some are therapy sessions whereby it is, hey, this is how are you feeling? What is this? Then some are psychoeducation that now learn about the addiction. Why are you addicted? The A to
underlying
Z.
causes.
Yes, the A to Z. Even learn about the other diseases. Because you see, as I said, not everyone is there for addiction. Some are there for other diseases. If it's depression, learn about depression. How does it occur? How does it manifest? Is it the same way? What is the smiling depression? The person didn't look depressed. They were assessed. No, said they've given me medicine and they've assessed me for depression. But this person was very happy. They can't be. So the family comes in and said he should not take those medicine, that medication. So we teach you about that. But we also not only teach you about the disease, but we also teach you about life. So you will have, because there are skills that are reskilling. There are skills that cut across. There are interpersonal skills that you have to do. There are financial skills. There are communication skills. There are delayed gratification skills. There are anger management skills. Because these are everyday things that you have to do. There is planning. If you're saying that you have to be in this and this, there's self-management in your free time, because we get that boredom. I am bored. So what is your self-management plan for when you don't have anything to do? Because even out there, you will not have things to do
all the time.
All the time. So
such is life.
Such is life. So if you're not having all things to do even out there, I know that some people default into the poor coping mechanisms. So we are saying, in your boredom, can you self-manage to that? We also have skills of personal hygiene. So there are several. So self-care. So there are several that every day there will be a facilitator-led session with a topic that is of importance to the person who is in our care. Okay, so then after that, so psychotherapy and the group therapy, and then we keep assessing. Then of course the element of the family.
Yeah, the family dynamics. I was going to ask you to
Yeah.
elaborate on how family dynamics play
I
into
feel like
this.
that's one of the reasons why Izzy and I decided to do this show. You know? When we came out of rehab, when I came out of rehab, just the family dynamics was one of the hardest things, and I know that it is for most of us. You know, so basically because they don't understand it as well as we do. They don't understand addiction as well as we do. They can't understand what we've been through. It's so easy for them to trigger you. You see, we're in that center for 3 months, right? We are getting all this psychoeducation and everything, but they're not.
In a
you know,
happy bubble.
But I know that. But I know that you try. So I think the question then is, what are we doing? Like, what are we doing to help families? You know, either.
Get
Yeah.
information.
Get information.
First of all, the addiction podcast is what?
Addiction Unfiltered.
Yeah.
The addiction unfiltered podcast is one of the ways. Let us speak about it openly there.
Yeah.
So if our parents chances to come across it, or we ask them to actually look for it,
Yes.
and then listen in, because I believe you're going to bring very many other people
Yes.
who can give you much more information, even your shared experiences,
Yeah.
Yes.
the lived ones. So, but the role of the family is very important
Yes.
in addiction care and recovery for the person. While at the center, even a near visit at the designated time is very empowering, because in most cases some people have come from home when they have broken relationships.
Yes.
Yeah.
The other one is annoyed, this one is also annoyed. This one might be remorseful, but the other one is still not happy.
Yeah.
The family is not happy.
Yeah.
So while the person is in care, and we emphasize this, that it is a three-way, it's a three-way approach.
Yeah.
The person who is in care gets support from the professionals, and then gets support from the family. While the center people say, what can we do? Come visit
Yeah.
on that day that is designated for visiting. Come have sessions.
Yeah.
Because we have a parent session
Yeah.
at least monthly.
Yeah.
Come and get that information. Ask all your questions that you need to. And we open the floor and say, okay, what do you want
Yeah.
to know?
Yeah.
And the experts are usually there arranged. Then come for the individual family sessions, because there are issues that need to be solved
Yeah.
within the family.
Yeah.
Then as a family as well, educate yourself beyond what you can get from safe places.
Yeah.
Educate yourself, because this is your person.
Yes.
Laura, 3 months or whatever, 2 months or
Yeah.
6 months or 1 year. If a person is in care for that period of time, that is only a small part of their life. And the majority of that life and the productivity and the wellness of that person is within that family unit.
Yeah.
Okay? So I urge the family to educate themselves, to
Yeah.
get to know what the diseases of their people are, addiction and other diseases,
Yeah.
or addiction occurring with other diseases. And when you become empowered with information, then you can better you're in a better position to support
Yeah.
your person.
Yeah.
And when I say support, people say, now you've come out of here, you're clean, I'm going to give you money to start a shop, 50 million. To start a what? So families think, what more can we, what support is support?
Yeah, support is they think it's something again tangible, you know, and yet a lot of I find that the support that is lacking, and what I'm hoping that we will do, and what, as you rightfully said, is that the awareness to break that part. The support is not, it doesn't have to be tangible. These people are as people are going through addictions with co-occurring things that are behavior, emotional, feelings. It's the mind. So the support is actually. I love what you've said about educate yourself further, because it's not about only the information you're being given. Like, come with an open mind and want to learn about this stuff, because there's just so much information out there as well, right?
Yes. And also, if it has to be with you, because I know much as we know that people do not cause the addiction, like people within you, within the people you live with, they do not cause the addiction, we know that.
Yeah.
And they also can't control it for you. They can't cure it for you. You have to be the one to get better from the addiction and start your recovery. But they can be a compounding or contributing factor to the addiction. So get to know your role in this, not for blame, but for better. I always tell people that I interact with that knowledge, awareness, the only reason you have to be aware and to get to know is to do better.
Yeah.
You can't get to know and just for the sake of just getting to know.
Yeah.
Okay?
Yeah.
You get to know, you do different, or you get to know, you do better.
Better.
There has to be a shift
Yeah.
in there. Okay? So then the family will say, this support is not a 50 million. Yes, it's intangible. And yes, it doesn't have to be, okay, now I'm going to take you back to school. You support the person the best way they need to be supported, or the best way that has been advised that you support the person.
Yeah.
If it is more presence with this person, or if it is engaging this person in the family activities, because by the time some of them, they have distanced themselves, or they have broken all these relationships, if it is bringing them back in the fold, if it is holding them accountable, because we don't want to leave that one out. You know, if it's holding a person accountable to their new skills or to their new ways of life, then you hold them accountable.
Yeah.
If it is the time for hand-holding when they need it, it is. If it is time for tough love when they need it, that is also support. So you support the person best way they need to support them. If it is understanding, that you actually merely understanding this person, then that is the support that they need. So it is individual, recovery journey is individual, getting sick is individual, but also there are similarities in the paths, and the solutions, all the tools that you need are also tailored. They should be to Laura. I cannot say that Laura and Easy institutions are similar, like completely. So if I advise maybe the parent of Easy, that maybe Easy should not go back to school immediately.
Yeah.
You know, I might say that Laura needs to go back to. Depends.
Yeah.
Different ways, yes. So I think that's it. Then when we do the assessments, the family comes in, we keep periodic, we give the family periodic assessment. Even the individuals, when we interact with them, give them where we feel that their stages are as in recovery, what we expect them to be doing at the center. That feedback is given to the people. And then if the people are ready for discharge, then we also plan the exit discharge. And I mean the exit plan. We do the exit planning, the relapse prevention, and we also give you information on the resources out there.
Yeah.
That you need to go online. You can get your AA online. You can get AAs in the different centers in Uganda. You can even join church groups. You can join these groups. It's also your choice. So we are giving you your tools into your hands. Take them into your hands. Take up your life and walk. Does our role as a treatment partner stop? No. We'll still be checking in. We check in, but also there is outpatient support. That we're saying that come for therapy. Come for therapy, continue your journey, but also not because just continuing your journey of addiction, but because life needs support. Yes, I think that's it.
One of the things I really loved about Safe Places is that they also have an outpatient center in Chambuko. So the one I went to is in Bujuko. Bujuko is on the way to Fort Portal.
Yes.
Yeah.
Okay, that sounds really far. It's only an hour, maybe an hour and a half out of town,
Yeah.
mainly because of traffic.
Yeah.
But yes, so they've also got Chambuko. Now, for me, that really, really helped. It gave me so much peace of mind knowing that I could still go and find the counselors there.
Yeah.
That I could still make an appointment, set up an appointment for every week and continue, with the recovery journey and everything.
Yeah. So Janet, one, you've given our audience, I think, so many beautiful nuggets, but is there something that you'd like, one last parting shot that you'd like the audience to know? Something, I don't know, call to action on how to break the stigma, build more awareness, or just one final thing that you'd like to put out there for the audience?
I think mine would be to women and to supporters of women and to caregivers of women, that hey, much as we are the most caregivers, that role falls on us, but we also need support. We also need support. So when we get into disease, then it is your time to show up. So we want you to show up for us. We want you to show up.
No judgment
for us.
Yeah.
We start with a non-judgmental attitude.
Yes.
Because I am a person, just beyond being a woman. And then also you also have to know that beyond being just a person, I am also like like I am an important person in your like in your puzzle.
Yes.
Yeah. So if I'm not well,
Yeah.
then your children will not be well, probably.
Yeah.
And not probably, it will
It will, yeah.
affect
Yeah.
the children.
The sooner
Yeah.
you do it,
And the better
Yeah.
for that, you
Yeah.
know.
yeah.
And then also the other aspect, maybe this is just going back. Like I see very many women coming into addiction because of their marital issues. Eh? So you do the therapy. Both of you need to do the support,
Yes.
and you get basically on footing that does not get you to sickness and to death.
Yeah.
Because addiction does lead to death.
Yes.
You know,
Yes.
it might not be that you will drink alcohol and it kills you, but you might smoke that weed and then you get an accident. Or you might drink alcohol and then fall in a ditch. Or you might get liver cirrhosis. Or you might actually even drink and die.
And die, yeah.
You know, so
Yeah.
it actually does lead.
It does.
Yeah.
lead to
it
death.
does, yeah.
So as women out there, I am not living out the role of men, but as we said, we are demystifying it.
Yes.
And for today, we are demystifying it for women.
Yes.
And we are saying that actually women do get into addiction.
Yes.
And women get into recovery.
Yes.
Women do get to recover, and they do recover. And when they recover, they are productive to themselves and to the people around them.
Yeah.
Maybe when you
Case in
get,
point.
you know,
Bye.
and you guys, by the way, I am so proud of you. Like super, super, super proud of you. You know, there is no greater joy than seeing someone pick up their life, and and hold the steering wheel and take it up and then become the person they are destined to be. It's wonderful.
Thank
No?
you.
Is thank you
Thank
so
you
much.
so much. Thank you. So as you can see, we really are trying to demystify addiction, and we're trying to be as real and raw as possible. So that's why we keep saying this is where the real meets the raw.
Yes.
Thank you so much, Janet.
You're welcome.
Thank
Yeah.
you. I think we'll put contacts for safe places in the comment section, our pages, Addiction Unfiltered, on all the platforms. Please reach out to us. You can tell us your story. We will always refer you to the centers, to basically all the counselors that we're in touch with.
Yeah.
So, thank you for tuning in, and
Like, share, subscribe.
see you next time. Thank you.
Thank you.